Before we commence on this enlightening journey, I would like to remind everyone to please silence your mobile phones or other electronic devices to ensure an uninterrupted experience. I request our Director R&D Cell of BLDE University, Dr. M. Patil, to please welcome the gathering.
Honorable Vice Chancellor Sir Dr. R.S. Mudol Sir, Honorable Pro Vice Chancellor Dr. Arun Inamdar Sir, esteemed guest Professor Dr. Surjit Singh Sir, Dean Faculty of Medicine, In-Charge Principal Dr. Samangala Patil Madam, Dean Allied Health Science Dr. S.V. Patil Sir, Registrar Dr. R.V. Kulkarni Sir, faculty members, and dear students, a very good morning to you all. It is a great pleasure and a sense of pride. I extend my warm welcome to all the dignitaries to the prestigious oration called Dr. M.B. Patil Oration Lecture 2023. Dr. M.B. Patil Oration Lecture was started in the year 2018 and it has conducted thrice in the last 3 years. The first oration was in the year of 2018 by Dr. Shashi Bala Singh, Director, Naipar, Hyderabad. The next of 2020, Dr. A.K. Singh, Director General, DRDO, Government of India. The third was Dr. Madan Gopal from KLE. The fourth oration is done by Dr. Professor Surjit Singh Sir. For this oration, I request our Honorable Vice Chancellor Sir to preside over today's oration lecture. For the benefit of audience and a guest, I would like to brief about the oration. This oration is instituted in the name of our Chancellor, Dr. M.B. Patil. He is also a President of a BLDE Association, to honor his accomplishments and contribution to the society in the field of education, plantation, and irrigation. At the outset, I will put on the record that Dr. M.B. Patil, our Vice Chancellor Sir, has conveyed his best wishes for this oration lecture under his name. And our Pro Chancellor Dr. Y.M. Jayaraj Sir also conveyed his best wishes for this oration lecture. For the benefit of our guest and audience, I will read out the brief biodata of our Honorable Chancellor Sir. Dr. M.B. Patil was born on October 7, 1964 in Torvi near Vijayapura. He had his early schooling in Vijayapura and graduated with BE Civil degree from PG Halgatti Engineering College, Vijayapura. He is a firm believer in quality education. He has visited various reputed institutions across the country and abroad with a view to adopt best practices which enhances the quality of education imparted in our institutions. He has succeeded in putting BLDE Association on educational map of India. Sir is at the age of 26. He shouldered the responsibility of association as a general secretary, became a president of association in the year 2005, and president of BLDE University in the year 2008. Under his dynamic leadership, the BLDE Association has developed new campus which is spread over 140 acres of land. Already the excellent infrastructure facility have been developed for offering commerce and MBA programs. He has been a 6-time MLA. He was a Minister of Irrigation, a Home Minister. Now he is a Minister of major industries. Sir has emerged as a popular leader of farmers and masses. His recent movement, a crusade for bringing Krishna water to the parched villages of Vijayapura district, will remain in the memory of people of this region in the years to come. Dr. M.B. Patil initiated a pioneering experiment in the state, lifting the river water to the dried up reservoirs at long distances and refilling them. This unique, massive effort has drawn the attention of entire nation. He has been aptly called modern Bhagirath. Dr. M.B. Patil is spearheading a popular movement called Koti Vriksha Abhiyana, wherein he is planting 1 crore sapling to increase the greenery in and around Vijayapura. He has been awarded with Basava Shanti, Shri Mrutyunjay Mahatma, Shri B.D. Jatti, and Karma Yogi, and many other awards. In brief, Dr. M.B. Patil is carrying on his young yet strong shoulder the great legacy of more than 100 years old educational organization with great responsibility. I again welcome you all for today's Dr. M.B. Patil Oration Lecture 2023. Thank you.
Thank you, sir. I now request Dr. Arun Inamdar, Honorable Pro Vice Chancellor, sir, to please introduce today's guest and M.B. Patil Oration Lecturer, Dr. Surjit Singh.
A very good morning to all of you. It's a great pleasure and honor for me to introduce today's oration lecture. Professor Emeritus Dr. Surjit Singh will be giving the oration today, and he is pediatrician by training. He has award of FRCP London, FRCPH London, and also fellowship in pediatric immunology London, and various other fellowships. He is currently head Department of Pediatrics and Chief Pediatric Allergy and Immunology Unit, and Chief for the Advanced Pediatric Center, PGMIR, Chandigarh, the most prestigious or one of the best or the prestigious institute of India. He is the one who initiated DM program in pediatric clinical immunology and rheumatology in the year Jan 2014. In fact, this is the unique one simply because this is the first and till date the only such course in India. He has a lot of international honors, like coordinator for the World Health Organization Collaborating Center for Education, Research and Training in Pediatric Immunology. And Sir is President of Asia Pacific Society for Immunodeficiencies. And he runs the Center of Excellence in Rheumatology, the first rheumatology unit in India. To his credit, there are many orations. In fact, I just shortened it to convey, to make aware that he has wide variety of interest and talks and orations. Twice he was awarded a prestigious Roland Levinsky Memorial Lecture, which is given by Hong Kong Society of Immunology, Allergy and Infectious Disease in 2016 and 2022. To get oration once itself is a big credit, but getting same oration twice means the amount of work he has done will speak. He has other honors like Associate Editor of International Journal of Rheumatic Diseases, Editor-in-Chief for the World Journal of Clinical Pediatrics, a Reviewer Editor for Pediatric Immunology as well as Primary Immunodeficiencies for the Frontiers in Immunology. And he is having also now that administrative responsibilities which he has taken at PGI Chandigarh. He was Joint Medical Superintendent, then Deputy Director Administration, and also Chief Vigilance Officer of Institution, and also he was in charge Director of PGI Chandigarh before the present Director. Before I really conclude his CV or introduction, we were having a small discussion after breakfast. With his permission, I would quote that interesting fact that his parents and roots were from the other part of Punjab. The agony with which the partition created and how his father carried Gray's Anatomy book, holding it in his arm because it was raining and he was on the top of railway because that was the days, the painful days. And literally his father has to take every page and dry it, and then later, in fact, he continued his medical education in Lucknow and served Indian Army, and the proud son of that Indian Army doctor who witnessed the partition pain, and still the very fact when he was telling, it was really a hair-raising thing for all of us we were hearing, that his father carried Gray's Anatomy in his arm. With this, I present to you today's orator, Professor Surjit Singh, to all of you. Thank you very much.
Thank you, sir. I now request Honorable Vice Chancellor Dr. R.S. Mudol, sir, to please felicitate our chief guest today. I request all the other dignitaries to please join, sir. I request our director, Dr. M.M. Patil, sir, to please welcome all other dignitaries on the dais with a flower bouquet. Thank you, sir. Now, without further ado, I call upon our chief guest, Dr. Professor Surjit Singh, sir, to please deliver today's Dr. M.B. Patil oration. I request all the dignitaries to please occupy the front rows of the auditorium.
This is forward, sir. This is backward. This is pointer for this. This is forward, backward.
And I can use these also? Good morning. It's really a very big honor for me and a very humbling experience to be asked to deliver this oration. I wish to discuss our experience of a disease that occurs in young children, a disease that is very challenging to diagnose, a disease that is very challenging to treat, and at the same time, a disease that is still not being diagnosed as often as it should be, not only in our own country, but across the world. And this is a disease that is likely to impact healthcare planning in our country in the years to come. So I talk about Kawasaki disease, which is now the most common cause of acquired heart disease in children in most countries, and I include India also in that. Acute rheumatic fever, with which all of us were so familiar, is now on its way out, and rheumatic fever has been replaced to a large extent by an epidemic of Kawasaki disease. So I start with my humble tributes to the Chancellor of this institution, Dr. M.B. Patil. My journey started in 1990 when I was asked by my head of the department to go and learn pediatric immunology at the Hospital for Sick Children, Great Ormond Street, London. And there I had the occasion to meet two giants in the field of pediatric immunology, the late Dr. Roland Lewinsky and Dr. Mike Levine. It was under them that I had the occasion to see my first few cases of Kawasaki disease. At the end of my training, I remember Dr. Lewinsky asking me whether I would get to see these children in India. And I said, sir, I'm not sure, because till that time, only 3 children with Kawasaki disease had been reported from India prior to 1990. But nevertheless, this is how I came. I came back to our institute, and gradually, under the mentorship of my professor, Dr. Lata Kumar, we started the pediatric immunology unit at the Advanced Pediatric Center in PGI Chandigarh. This disease, which we now call Kawasaki disease, owes its origin to this remarkable Japanese pediatrician, Dr. Tomisaku Kawasaki. And these are photographs from his own personal collection. This is how he looked like in 1952. 1952, remember, was just 4 years after the end of the Second World War, when Japan had virtually been flattened. It was a country in distress. Dr. Kawasaki came from a very humble background, and his family was facing a lot of financial difficulties as a result of the war. So it was at this time that he had completed his medical education from the University of Chiba, and he was waiting to get a job. He was offered 2 positions. One was a very prestigious position at the University of Tokyo in a teaching hospital, and the other was in the Japanese Red Cross Medical Center as a staff pediatrician. Now, anyone given this choice would have opted for the University of Tokyo position, but since that was a non-paying job, it was difficult for Dr. Kawasaki to accept that position, and he joined as a staff pediatrician at the Japanese Red Cross Medical Center, which was a service hospital. and it was nothing bigger than a small district hospital. This hospital is not very far from the center of Tokyo. So he joined this hospital because it was paying him for his services. Little was he to know that this decision of his would impact medical science for the next 100 years. So he joined as a staff pediatrician at the Japanese Red Cross Medical Center. This is how it looked like, a small nondescript hospital, just like any other small hospital, service hospital. And these are again photographs from Dr. Kawasaki's personal collection. And like all pediatric wards, this was a very active pediatric ward treating children with pneumonia, diarrhea, and the usual pediatric illnesses. Dr. Kawasaki liked working with children. He simply loved children. And this was very obvious to us when he visited our institute in 2005. The moment he saw young children, his face would light up. So he was a born pediatrician, so to say. It was on 4th January 1961, while working on a night shift, that Dr. Kawasaki came across a 4-year-old boy by the name of Shunichi Yamazo. And in his own words, this child had fever, rash, and red eyes. I could make no diagnosis of this unusual sickness for which I could find no reference in any medical center, in any medical literature. I presented this case at a clinical conference in the hospital. One doctor suggested it was atypical scarlet fever, but I knew it was not. Why it was not scarlet fever? Because in scarlet fever, the eyes are not affected. In scarlet fever, the lips are not affected. So because of these clinical findings, Dr. Kawasaki said, I knew this is not scarlet fever. Finally, the case was released as being of unknown diagnosis. This is the exact English translation of his notes written in the Japanese language. So the patient was discharged as being of unknown diagnosis, but Dr. Kawasaki kept a record of this child's illness. He came across yet another child the next year. He could immediately connect that these two children had the same illness. By 1967, he had collected 50 such patients. And at the prodding of his mentor, he published them in the Japanese Journal of Allergy. This was a Japanese language journal, not read outside of Japan. And he could not publish this in the Japanese Journal of Pediatrics because the big professors at the Tokyo University never let him do that. So they said, who is he to dare diagnose a new condition with which we are not familiar? So they did not let him publish it in the Japanese Journal of Pediatrics, and he had to rest content with this being published in the Japanese Journal of Allergy. This article is more than 40 pages. We now have an English translation of this article, and Dr. Kawasaki meticulously recorded the findings of all 50 patients, and he repeatedly said that this is not scarlet fever because in scarlet fever the eyes are not involved, the lips are not involved. So he called it the Japanese equivalent of mucocutaneous lymph node syndrome. Since it was in the Japanese language, it attracted no attention outside of Japan, but within Japan, people started talking about this condition. It was in 1974 that Dr. Kawasaki published this, his experience in the English language literature in the journal Pediatrics, the Green Pediatrics Journal of the American Academy of Pediatrics. And here he is seen sitting with Dr. Fumio Kosaki, who was his mentor at the Japanese Red Cross Hospital, and it was Dr. Kawasaki who encouraged him to publish this in the English language. Now, till 1967, Dr. Kawasaki was not aware that this disease has any cardiac complications. So he just described this as a self-limiting mucocutaneous lymph node syndrome. But what happened between the 67 publication and the 1974 publication was that a few of these children whom Dr. Kawasaki had described suddenly died. And when an autopsy was done on one of these children, they found large coronary aneurysms. This autopsy was done by the pathologist at the Japanese Red Cross Hospital, Dr. Tanaka. So when Dr. Tanaka showed these aneurysms to Dr. Kawasaki, he said this could be just coincidental. He never believed that this disease can have coronary sequelae. Then another child died, and then more deaths occurred across Japan in children who had features similar to Kawasaki disease. So this made the Japanese Ministry of Health suddenly wake up, and they started collating national data on this disease, which at that time was still not called Kawasaki disease. But they started collecting data nationally, and soon it was apparent that a proportion of these children with these symptomatologies had died. And very reluctantly, Dr. Kawasaki accepted the fact that this disease has some cardiac complication and it focuses itself on the coronary arteries. Kawasaki disease first found a mention in our textbook, Nelson Textbook of Pediatrics, in the year 1979, when there were hardly 2.5 paragraphs on this disease. We read Nelson in 1984, and it had a brief description of Kawasaki disease, but this was one of those conditions which we thought we would never get to see, in India at least. So what is Kawasaki disease? It's a medium vessel vasculitis with a special predilection for the coronary arteries. It usually affects children below 5 years. However, older children and adolescents can also be affected. The diagnosis rests on the recognition of a characteristic constellation of clinical findings. It is still a clinical diagnosis, completely a clinical diagnosis. That is a challenge of this disease. Even after 57 years of Dr. Kawasaki's original description, there is no pathognomonic laboratory test for this diagnosis. So most of the vasculitic disorders that we deal with have clinical diagnosis only, but nothing as prominent as Kawasaki disease, where it is just your impression which makes all the difference. The window of opportunity to act on that impression is only 3 to 4 days. If you delay the diagnosis, the damage would already have been done. So that is the biggest challenge of Kawasaki disease. Why should Kawasaki disease be diagnosed and treated? Because this is not a benign disease of childhood. If left undiagnosed, left untreated, it can result in serious coronary artery abnormalities that are seen in 15 to 25% patients. Almost 1/5 of patients who are not diagnosed, not treated, will develop serious coronary artery complications. But what has now emerged is that even when you treat these patients, 3 to 5% children will still develop coronary artery abnormalities in spite of treatment. And for a disease as common as Kawasaki disease, this seemingly low figure of 3 to 5% is very significant. In a small city like Chandigarh, which has a population of around 10 lakhs, prior to the pandemic, we were seeing something like 100 to 150 children with Kawasaki disease every year. That is how common this disease is. So one can well imagine the numbers which would be there in metropolitan cities like Bangalore, Delhi, Mumbai, Hyderabad. Unfortunately, overwhelming majority of these children are still not being diagnosed. They come with fever, they come with red eyes, red lips, They are offered antibiotics, and quite often one antibiotic after another till it is too late. Patients with coronary abnormalities as a result of childhood KD remain at risk of significant cardiac complications later in life. So these are the CT angiographs of a child with Kawasaki disease who developed aneurysms in all the 3 coronary arteries. What is the global epidemiology of KD? Kawasaki disease is most common in Japan. The second highest incidence figure comes from Korea. The third highest incidence figure comes from Taiwan. That is all 3 countries in Northeast Asia. Why that is so, we don't know. But what is also very clear is that in these 3 countries, the incidence is still increasing. The incidence in Japan today is twice what it was 20 years ago. And this incidence is not coming down. In the lower part of the graph, we have incidence figures from Europe, Australia, North America. Here, the incidence is not only lower, but the incidence has plateaued. But in the Northeast Asian countries, for reasons that are not clear, the incidence is still going up. In Japan, which has a population of around 120 million, 12 crores, they diagnose approximately 14,000 new cases of Kawasaki disease every year. 14,000 new cases. And the total number of KD diagnosed in India would not be more than a few thousand. So that is the degree at which we are missing these patients. So the same incidence figures depicted in graph form. Japan, Korea, and Taiwan. The 4th country is Singapore, again an Asian country. So these 4 countries have the highest incidence figures across the world. So we categorize these into category 1 countries like Japan, Korea, and Taiwan, where the incidence rates of KD are in the range of 80 to 350 per 100,000 children below 5, and incidence keeps on rising in these countries. In category 2, we have the Western world, Europe, North America, and also Australia and New Zealand, where the incidence rates are between 15 to 30 per 100,000 children, and incidence in these countries has plateaued. In the 2 most populous countries, China and India, we do not have nationwide data. We only have city-specific data. So in China, the incidence is fairly high in the coastal cities, Shanghai, Beijing. Here, the incidence rates are in the range of 43.1 from Shanghai, 55 in Beijing, and in the island of Hong Kong, it is 74 per 100,000 children. In India, we have city specific data from Chandigarh, and we have recorded an incidence of 10.6 per 100,000 children below 5, and our incidence figure is similar to what is there in Europe and North America. Kawasaki disease has some association with rising GDP values. And it is no coincidence that in Japan, this is the graph showing the incidence of Kawasaki disease in red. And the 3 peaks in between are the 3 nationwide epidemics that had occurred in Japan. So this incidence of KD followed an increase in the GDP of Japan after the Second World War. So the first few cases were recorded in the early 60s in Japan. And remember, Tokyo had hosted the Olympics in 1964. So their economy had already gone up. And it was around this time that they started picking up KD. Something similar occurred in South Korea. Their economy started going up in 1990. Their KD incidence started going up around 80s to 90s. And this is how their economy went up, the GDP in black. In India also, our economy took off around 1990 when India opened up. The first series on Kawasaki disease came in 1997, February 1997, and this was from Trivandrum. The second series came from Chandigarh in September 1997, and the third came from Calcutta, again a few years later in 2000. Again, is it a coincidence that all these three series came as the economy went up? And this has been an experience over the last many years that Kawasaki disease usually does not occur in very poor children. It usually occurs in the affluent families. Whether that has something to do with the hygiene hypothesis or something else, we don't know. But there is a distinct association of KD with the socioeconomic status. In India, the first case of KD was reported by Dr. Arvind Taneja from Delhi in 1977. And he reported this as mucocutaneous lymph node syndrome because that is what this disease was called at that time. Dr. Taneja says that he was able to diagnose this condition because he had seen a similar child while doing his fellowship at Boston. And Dr. Taneja was also a faculty member at PGI Chandigarh before he went to Delhi, and he was also a student of our mentor, Dr. B.N.S. Walia. The second case of Kawasaki disease was reported by Dr. Nitsure from Pune, and by this time the name had changed to Kawasaki syndrome, and Dr. Nitsure, who still works at the Ruby Hall Clinic, that was from where she described this condition. Both the parents of this child were medical doctors. So their child started running fever, for which they had no cause, given antibiotics, no response. Ultimately, on the rounds, Dr. Nitsure noticed that this child had developed a swelling in the axilla, which she thought at that time was an axillary lymph node, suppurative lymphadenitis. So she felt happy that now she'll be able to get a diagnosis. She put in a needle and got out blood. So this was an axillary aneurysm because of Kawasaki disease, and this child also had coronary aneurysms. This child was ultimately taken to Birmingham Children's Hospital in the UK. They tried doing bypass grafting for the coronary thrombosis, but ultimately this child could not survive. So this was the second case of KD from India. The third case was from Christian Medical College, Vellore. This was an adolescent child reported from the Department of Internal Medicine by Dr. Seshadri and Cherian. We picked up our first patient in June 1994, and when we offered a diagnosis of Kawasaki disease, as is usual, this was met with lot of skepticism, doubt, criticism, whatever. When we presented this in our institute clinical meeting, there were more disbelievers than believers amongst the audience. Anyway, this was the first child in India where treatment with intravenous immunoglobulin was used during the acute stage, because by that time, IVIG had become available in India. And we reported this in Indian Pediatrics in 1996. In October 2005, we had the privilege of hosting Dr. Kawasaki and his friend, Dr. Hirohisa Kato, at PGI Chandigarh. When we invited him in 2004 to visit us, his only question was, are you seeing this disease in India? We said, yes, we are seeing it. So he said, okay, I'll come. And come he did. And this is Dr. Kawasaki at our institute. And in the background, you can see Dr. Hirohisa Kato, who was a pediatric cardiologist who worked with Dr. Kawasaki for more than 50 years. Dr. Kato was the first cardiologist in the world to do coronary angiographies in small children to demonstrate the aneurysms. At that time, there was no echocardiography available. So his only option was to do angiographies. He did coronary angiographies, and he says the equipment was so primitive that everything had to be improvised. The children had to be anesthetized. And on these children, he was able to show aneurysms in Kawasaki disease. So he was the first pediatric cardiologist to demonstrate aneurysms in living children. He's still alive, Dr. Kato, and although Dr. Kawasaki had passed away. And as I said, Dr. Kawasaki used to bloom in the company of children. So in the photograph on the right side, he's seen with a child who had Kawasaki disease, and he's seen interacting with the parents. After this visit, I think the skepticism with regard to KD in India decreased significantly, because anyone who heard Dr. Kawasaki and Dr. Kato realized that this disease is for real. We started compiling our epidemiological data, and between 1994 to 2008, we showed a steady increase in the number of cases. Now, whether this was because of a real increase in the incidence or because of more ascertainment of cases remains conjectural. Maybe it is because of both, but more and more physicians, more and more pediatricians, and more dermatologists at Chandigarh started diagnosing Kawasaki disease. Why dermatologists? Because in many children, the rash is very prominent. Sometimes the eye signs are so prominent that the ophthalmologists refer the child to you. So many systems can be involved in Kawasaki disease. So it depends on the threshold at which your colleagues are working in the hospital, and on that will depend the number of KDs that you will pick up. So this is our incidence data from 2009 to 2014, and at present the incidence is 10.6 per 100,000 children below the age of 5 for the city of Chandigarh, which is approximately equal to what is happening in Europe and North America. What are the diagnostic criteria? I'm sure most of us know these. Fever for at least 5 days, presence of 4 of the following 5 conditions: conjunctival injection, rash, cervical adenopathy, mucosal changes, acral skin changes, which in the acute stage are edema and erythema. In the convalescent stage, there is periungual desquamation. Now, there have been several modifications of these diagnostic criteria, but the criteria that Dr. Kawasaki gave in 1967 are more or less valid even today, in spite of many refinements. And these criteria are the ones that Dr. Kawasaki offered in 1967, based on his clinical assessment. The diagnosis is completely clinical, and you have to identify a temporal sequence of a constellation of clinical findings. By this I mean that most of these findings appear for only a few days. Redness in the eyes may be there for just 3-4 days. If you miss it, you miss it. The rash can be very transient. The red lips can be very transient. The cervical adenopathy may disappear. So it is a constellation of these clinical findings. What happens is that a child starts running fever, mother goes to the first pediatrician who gives her some antibiotic, fever persists, she changes her pediatrician, he changes yet another antibiotic, he may see some findings which the previous doctor may have missed. The fever persists and it goes on and on. And that is how these children get missed. So at PGI, what we do is, if you suspect Kawasaki disease in a child while sitting in the outpatient clinic, we try to admit these patients so that the sequence of events can be picked up. And if it doesn't turn out to be KD, well, you just discharge the patient. But unless you see the child on a day-to-day basis, you are likely to miss the diagnosis. So in the first 10 days, you see these very typical findings. This is our case number 2 at PGI, Kawasaki disease number 2, which we diagnosed in 1995. Look at the irritability in the child, the redness in the eyes. Now, this is not conjunctivitis. This is conjunctival injection. The eyes are red, but there is no discharge like you see in measles. It's not conjunctivitis. The child doesn't get up with sticky eyes. It is just conjunctival injection. Look at the irritability in the child, which is so very typical. The child is anxious, irritable. Look at the red lips. Look at the cracked lips. These cracks are vertical cracks. Look at the red tongue, which is typically called the strawberry tongue. This child, if you see in the outpatient clinic, and if you have some experience, there is no differential diagnosis. This is KD, as simple as that. A close-up of what the strawberry tongue can look like. The cervical adenopathy can be very difficult to pick up. The definition says one node more than 2.5 centimeter. Now, one node more than 1.5 centimeter. Now, that is hardly anything. So unless you look for it, you will miss it. And this is the most non-specific finding in Kawasaki disease. It is usually not as prominent as in this child. So here again, along with the cervical adenopathy, look at the red cracked lips. So that diagnosis is very obvious. The redness is rarely as prominent as in this child. You have to hunt for it. And this conjunctival injection is very typical because there is perilimbal sparing. So just around the cornea, the vessels will stop short of touching the cornea. So this perilimbal sparing, again, you have to hunt for it. Unless you're looking for it, you will miss it. So conjunctival injection with typical perilimbal sparing and no discharge. That is typical of KD. The rash can be very, very variable. And this is where our dermatology colleagues come up. Many patients at PGI are referred from the dermatology services. This rash can be macular, can be maculopapular, can be an erythroderma-like rash. If you have rash and fever in a child, whether you're a dermatologist, whether you're a pediatrician, think of KD. Measles now is very uncommon. Measles is on its way out, fortunately, because of the immunization. So rash in a child who has fever, your first diagnosis has to be KD. Rule out KD, otherwise you will miss it. This was one of our first few patients with KD who developed erythroderma, generalized erythroderma. Again, look at the irritability in the child, the red lips in the child. You have swelling of the hands and feet, very typical of KD. This is the only medical condition in which you get swelling in the hands and feet, but in infants, this can be very easy to miss. However, an observant mother will not miss it. And if the mother notices swelling on the dorsum of the hands in a febrile child, there is no differential diagnosis. The swelling on the dorsum of the hands is the most specific finding of Kawasaki disease, the most specific finding. There is no differential diagnosis. So again, showing the swelling in the hands and feet. A close-up. But you can miss these findings, especially in infants. Again, okay. What is the DD? Hardly any differential diagnosis. If you have picked up the first 5, 6 patients of your career, most of the time you will write on the slip KD and nothing else. But Dr. Kawasaki differentiated this from scarlet fever, which is basically a streptococcal toxin-mediated disease, and Stevens-Johnson syndrome. In scarlet fever, this is a disease of older children, more than 2 years old. Eyes will not be involved, lips will not be involved. And scarlet fever responds dramatically to antibiotics. You give one course of antibiotic, even a broad spectrum antibiotic, the fever should come down within 12 hours. In KD, it has no response on the fever. Stevens-Johnson syndrome, the rash can be very challenging. Sometimes it can mimic KD findings. But if you have a Stevens-Johnson syndrome and the child is running high-grade fever, think of KD. So whenever we have children with Stevens-Johnson syndrome and they are admitted either in dermatology or in our ward, KD will always be considered. And we have to work very closely with our dermatology colleagues because they'll pick up findings which we miss. So, but this is a dangerous area where KD can be easily missed. We have to diagnose KD in the first 10 days based on these findings. And that is the challenge of KD, because if you delay the diagnosis beyond 10 days, then the chances of coronary artery damage increase. But After 10 days, the diagnosis is somewhat easier to make, but then you have, in a way, missed the boat already. What do you see after day 10 is the desquamation, the typical periungual desquamation, the skin peeling off around the nails, very, very typical of KD, just around the nails. And then the whole, the skin may peel off over the hands and feet, but this occurs around day 10. It is too late to diagnose KD. But we will still treat children with KD even if you pick it up at this stage. But this is the typical desquamation of KD. There is, again, virtually no differential diagnosis for the periungual desquamation that you see in KD. This is how it looks like from close-up, periungual desquamation, but can be very, very difficult to pick up when KD occurs in babies below 6 months. You really have to struggle to pick up this desquamation. Again, showing the periungual desquamation, the peeling. So all these features are seen for a few days. During the convalescent phase, we see what are known as Bowes lines, and these are the lines which we see on the first follow-up visit, which is around 4 weeks after we discharge the child. These are horizontal ridged lines. If you run your fingernail on the line, you can feel the ridge. So these are the Bowes lines of Kawasaki disease. This is the only sign of Kawasaki disease which persists for more than a week. It will persist for several weeks, because these lines start at the base of the nail and grow distally. So these are the Bowes lines of Kawasaki disease, but they can also be seen in any other serious febrile condition of children. Serious typhoid fever also, sometimes on discharge, you can see the Bowes lines. But in Kawasaki disease, they are very typical. So these are again the Bowes lines of Kawasaki disease. Lab investigations, we work up these children for other causes of fever, rule out other causes of fever, because you cannot afford to miss some other treatable condition. Children with KD will usually show leukocytosis, thrombocytosis, raised ESR, CRP is elevated. Urine would show pus cells. This is because of the urethritis of KD. So in a febrile child, when you have pus cells in the urine, don't jump to a diagnosis of urinary tract infection. This mistake has occurred several times. You are struggling with the cause of fever, suddenly you find a urine examination that shows pus cells, you think this is UTI, and you start some other antibiotic, and that delay can be critical. So sterile pyuria in a febrile child, there is only one differential diagnosis, and that is Kawasaki disease. Echocardiography is not essential for diagnosis of Kawasaki disease, just as echocardiography is not essential for diagnosis of acute traumatic fever. We do not need a cardiologist to diagnose Kawasaki disease. This is the pediatrician's domain. We cannot share this responsibility. This is too big a responsibility. The cardiologists can fine-tune our approach, but we don't need an echocardiography during the acute stage. If it is available, well, it's useful. But you should not refer a child with Kawasaki disease to some other city, some other hospital, just because you do not have access to a good echocardiography examination in your own hospital. It remains entirely a clinical diagnosis. Several biomarkers have been studied, but there is no biomarker which has reasonable or foolproof sensitivity and specificity. We have worked on pro-brain natriuretic peptide, pro-BNP in children with Kawasaki disease, and a cutoff level of 1025 picogram per ml. We found that in a clinical setting, if you have pro-BNP above this level, it has 88% sensitivity and 96% specificity. So we use the pro-brain BNP very frequently whenever we are working up children with Kawasaki disease, but otherwise there is no diagnostic laboratory test for Kawasaki disease. The problem with KD is that there are many caveats to the diagnosis of Kawasaki disease. So like most other diseases, there are typical and atypical forms, but more so in Kawasaki disease. The criteria that we had mentioned initially, they will be fulfilled by no more than 50% children. So that means at least 50% children of Kawasaki disease will have the disease without fulfilling the criteria. So this is because the criteria are inexact, inaccurate. We do not have robust criteria for diagnosis of Kawasaki disease, and that increases the challenge before the pediatrician. So we have many outliers to the diagnosis of Kawasaki disease. So there are some clinical features that are pathognomonic of Kawasaki disease but are still not included in the criteria. A 2-year boy, fever for 7 days, rash, who had perianal peeling. Perianal peeling. Now, perianal peeling is pathognomonic of KD. If in a febrile child, so always remove the diapers in febrile children. If you see this perianal peeling, because this will occur in the first few days of life, first few days of fever. You will see this even on day 3, day 4. If you see perianal peeling in a febrile child, this is KD, irrespective of whether the criteria are being met or not. Similarly, 8-month boy, fever for 7 days, rash, who had BCG site reactivation. Now, BCG site reactivation, there is no differential diagnosis. If in a febrile child, the BCG site suddenly becomes active, this is Kawasaki disease. But these are the features that are not included in the criteria. But as a pediatrician, we should never miss these findings. We always look at the perianal area. We always look at the BCG site whenever we are dealing with children with KD. What are the other caveats? Several patients, more than 30 to 50% patients, will not meet the diagnostic criteria. So they have what is called incomplete Kawasaki disease. This was a 5-year-old boy, had been running fever for 17 days, and had been given several courses of antibiotics. Fever was persisting, the child was irritable, no other symptoms and signs. Now what happened is this child entered our emergency ward. The resident doctor thought that he's got enough antibiotics. He wanted to rule out infective endocarditis. So he got an echo done to rule out infective endocarditis, and on echo, instead of infective endocarditis, they saw large aneurysms. And this is a CT angio done on this patient later, which confirmed the giant aneurysms, and this child remains on heparin now for more than 7 years. Clinical presentation, just fever. So this is how dangerous incomplete Kawasaki disease can be. Some children have atypical Kawasaki disease. What do we mean by atypical Kawasaki disease? Normally, renal system is not involved in KD. It is a vasculitis, peculiar vasculitis, where kidneys are not involved. In most other vasculitic disorders, kidneys are involved. CNS is not involved in Kawasaki disease commonly. But in some children, you have predominant systemic involvement in KD. And that is what is called as atypical KD. So you can have a pulmonary presentation, you can have a renal presentation. We have children who presented with jaundice, hepatic presentation, children who had diarrhea, fever and diarrhea. So because it's a vasculitis, it can affect any system, but this is what is called as atypical KD. Incomplete KD and atypical KD are by no means milder forms of KD. In fact, the converse may well be true, because here the diagnosis gets delayed and therefore the treatment gets delayed and they have more chances of complications. Then KD, as I said earlier, is usually a disease below the age of 5. But in some children, it can occur in babies. And for a pediatrician, there can be nothing more challenging than diagnosing and treating KD in the first few months of life. It can be a nightmare. So here is one of our publications in which we had described a few children who had KD below the age of 6 months. These children will almost always have incomplete forms of KD. The criteria will never be fulfilled, and that is a challenge. If you delay the diagnosis, they will get the most serious complications because KD is most severe in young infants. Occasionally, you will get KD in adolescents and adults. Again, it is very challenging because adult physicians may not have a low enough threshold for KD. So this was a medical doctor. She was 27 years old, developed fever went on and on. Ultimately, she had full-blown desquamation, went to a dermatologist who diagnosed KD, and the child was referred to us, and this is one of the few instances where we had to admit an adult patient in the pediatric ward. So she was 27 years old, whom we admitted. She had developed aneurysms by the time she was admitted, but fortunately, these aneurysms regressed. Macrophage activation syndrome can be the presentation of KD. Like all rheumatological disorders, lupus can present for the first time with macrophage activation syndrome. Systemic JIA can present with MAS. Dermatomyositis can present with MAS. And KD can also present with MAS. When it is very severe Kawasaki disease, the initial presentation can be just like macrophage activation syndrome. So instead of thrombocytosis, you can see thrombocytopenia. So it requires, the judgment, the experience, and all the skills that the pediatricians have to pick up this presentation of KD. To complicate things further, Kawasaki disease is not only coronary arteritis, but it is also a myocarditis. And this concept was given by Dr. Najib Dada from Montreal, who had been to PGI in 2018 when we held our conference on Kawasaki disease. And according to Najib Dada, while coronary artery abnormalities can occur only in 15 to 25% patients, myocarditis is almost universal. And in some patients, this myocarditis can present as frank congestive cardiac failure. So if you have a child in the emergency who has fever and congestive cardiac failure, this may not be viral myocarditis. In viral myocarditis, congestive cardiac failure usually occurs after the fever has subsided. It's a post-viral phenomenon. But if you have ongoing fever and congestive cardiac failure, think of Kawasaki disease. In some children, this myocarditis and congestive cardiac failure can be so severe that it can present as KD shock syndrome. So if you're taking rounds in the intensive care unit and you have a child who is in shock, you think this is septic shock, cultures are sterile, the child is not improving, this could be KD shock syndrome. And this is one of our patients with Kawasaki disease and KD shock syndrome, the most difficult child with KD that we have ever managed in the last 30 years. This child required 3 courses of intravenous immunoglobulin, required infliximab, required methylprednisolone, oral prednisolone, ventilation, oral cyclosporin before the child recovered, but recovered completely without aneurysms. So if you pick it up early enough, these children can be salvaged. So KD is much more than just coronary arteritis. So you can have myocarditis, you can have valvular involvement, you can have frank mitral regurgitation in these patients, you can have pericarditis, you can have aortic root anomalies. So it's a very broad spectrum of cardiac involvement that can occur in KD. It is wrong to say that KD only presents with coronary artery abnormalities. So we have what is now we call as the expanded spectrum of KD, which basically highlights that since KD is a vasculitis, it can affect virtually any body system. And you can have children with KD who have pauci-articular presentation, that means just with fever. You can have KD shock syndrome myocarditis. You can have children who present with macrophage activation syndrome. You can have children who present with incomplete forms of KD. You can have children who present with peripheral gangrene, and that can be because of KD. So your threshold for KD in a febrile child has to be really very low. Missing a diagnosis of KD can have serious consequences that last a lifetime. So this was a 17-month girl, fever for 3 days, irritability, generalized rash. Urine examination showed pyuria, so it was treated as urinary tract infection. Fever went on and on, multiple investigations done. Ultimately, the child showed periungual desquamation. This was the time when KD was diagnosed, but it was too late. This child already had developed giant aneurysms in all 3 coronary arteries. So this is the CT coronary angiography on the same patient. How do we treat Kawasaki disease? The standard treatment is intravenous immunoglobulin, 2 grams per kg, single infusion, along with aspirin. The dose that we use these days is 30 to 50 milligram per kg per day for the first few days, and then we shift over to 3 to 5 milligram per kg per day for 4 to 6 weeks. And this treatment regimen we owe to the efforts of Dr. Furusho from Kyoto and Dr. Jane Newberger from Boston. So this is the treatment, standard treatment for Kawasaki disease. However, many children with KD require preemptive intensification. By this I mean is, suppose we have a young infant with KD, we will not be content with IVIG alone. Suppose we have a 4-month-old baby with Kawasaki disease, this child would require first infliximab, then IVIG, then methylprednisolone, followed by oral prednisolone and cyclosporin. We'll be that aggressive, because in this age group, the chances of coronary involvement are very high. So this is what is called as preemptive intensification, which is required for KD in infants, especially very young infants, especially boys. Children who have very severe disease, for instance, children who develop severe myocarditis, and when there are coronary artery abnormalities at presentation, that means the child presents with KD and the echo shows already coronary damage. So in these patients, IVIG alone is not enough. You have to intensify your treatment, and this concept was given by Dr. Jane Burns from San Diego. Then you have IVIG resistant KD. That means children with KD who do not respond to IVIG. That means the fever persists even after the first dose of IVIG, and this happens not infrequently. It happens 10 to 15% of the times, and here again you would need to add therapy. Our preferred drug is infliximab, but you can also use glucocorticoids or cyclosporin. Echocardiography has been the preferred imaging modality in KD. We use it all the time, but echocardiography is not enough for many reasons. Number one is that a normal echocardiographic examination does not rule out KD. The first changes of KD appear after day 7. If the echocardiographer is not experienced enough in doing echo in small children, he will miss the findings. Doing echo in young children with KD, tracing the coronaries is not everyone's cup of tea. And adult cardiologists may not be trained to do such examinations. Then the left circumflex coronary artery, the distal segments of coronary arteries can all be missed on echocardiography. So although echocardiography is useful, this is not the ideal imaging modality. We need to supplement this by CT angiography, and this is a very special CT coronary angiography. It should not be done by a radiologist who does not have experience. So we do it in PGI. It's only one radiologist who does it. It is he who has developed the protocol to do this. And if he's on leave, we don't do the procedure. As simple as that. So he has worked with the CT manufacturer, developed a protocol, developed a software by which we can do the CT coronary angiography at less than 1 millisievert radiation. This is the lowest radiation reported for CT coronary angiography, And this is done by Dr. Manfool Singhal, who is a professor of radiology. And he's been working on this for the last 9 years. But please do not get CT coronary angiography done as a routine. You will get not only not get enough information, it requires a lot of skill because these children have tachycardia. Doing CT angiography in that state can be difficult. So we have to first give them a beta blocker, oral beta blocker. We do it without sedation, without anesthesia. We just sedate these children, give a beta blocker, but it's a whole team that does it. So 2 residents from our department will go there, and Manfool will do it himself. So it's a very skilled procedure, but ever since we have started doing this, we have realized how serious this disease is. So this is our experience on distal coronary abnormality involvement in KD. Hitherto, it was believed that KD does not involve the distal segments. It's only the proximal segments that are involved. But that was based because the imaging was done by echo. Echo missed the distal findings. Once we started doing the CT coronary angiographies, we showed that distal coronary involvement can also occur in these children. So these are examples of distal coronary involvement, giant aneurysms in the distal coronary involvement, and some children can have only distal coronary involvement. The proximal segments are normal. So these are again examples of distal coronary artery involvement. Then the left circumflex coronary artery. This can be missed entirely on echocardiography because of the anatomical localization. So this is a child who has an aneurysmally dilated left circumflex coronary artery. Again, the left as large aneurysms as this, which can be completely missed on routine echocardiography. Kawasaki disease can leave behind many sequelae. So starting with coronary sequelae, this is thrombus formation and an aneurysm in the left ventricle. In the middle photograph, you can see the aneurysm of the left ventricle secondary to thrombosis of the coronary arteries. So this muscle has got infarcted and it has developed an aneurysm. You can get complex aneurysm formation. Again, these will be missed on echocardiography. You have what is called pan-coronary dilatation. This is something new. Normally, the literature on KD is focusing only on the main coronary arteries, the left main coronary artery, right coronary artery, circumflex coronary artery. But sometimes the branches of these coronary arteries can also be involved. So this is what is called as pan-coronary dilatation, which again can be picked up only on CT coronary angiography. Occasionally you can get systemic arteries that are involved in KD. This is an example where the aorta and its branches were involved in KD, just like Dr. Nitsure's patient who had developed axillary artery involvement. This was a 1-year-old girl who presented in 2010, diagnosed with KD, had developed aneurysms in spite of IVIG. She remains on anticoagulation and aspirin. When we did the CT coronary angiography in 2021, this is what it looks like. Dense calcifications. Now, once these calcifications occur in children with KD, when she grows up, if she has to need either a bypass graft or even angioplasty, these arteries are not amenable to any of these procedures. This would be missed on echocardiography. This is only on CT coronary angiography that you can pick it up. As I said earlier, there can be myocardial sequelae of KD, as was highlighted by Dr. Najib Dada. And this is the MR angiography that we have done on our follow-up of our patients. This was done 10 years after the diagnosis of KD, and this shows late gadolinium enhancement in the apex, which basically means this is a marker of myocardial fibrosis. That fibrosis has already occurred in these patients. Coronaries are normal. So myocardial involvement can occur independent of coronary involvement. Children with KD who are not treated, they can develop many other complications. So you can have systemic complications in the form of abnormal responses of the main coronary arteries, So you can have endothelial dysfunction in these main large arteries. So you can have lot of endothelial dysfunction. You can have changes in the carotid intima media thickness. These are all sequelae of KD, well recorded. This is an adult angiogram and done by our adult cardiologist. He found that this patient had aneurysms. These were not atherosclerotic aneurysms because in atherosclerosis, the entire coronaries are involved. These were patchy aneurysms. Patchy involvement does not occur in atherosclerosis. So these children had KD in childhood, which had been missed. They were left with aneurysms. When they became adults, thrombosis occurred, and they landed up in the adult coronary care unit. So these are the long-term sequelae of KD. So when you have a young adult in the coronary care unit who has no risk factors for coronary arteritis, who has no family history of coronary involvement, this could be a sequel of childhood KD. Again, this is a CT coronary angiography of a patient. This was a DSA. This is a CT coronary angiography of an adult who had KD during childhood. KD can kill. Our mortality rate is 0.87%, and most of these deaths have occurred in young infants with KD, where the diagnosis was delayed, children were referred late, or those who had very severe disease. So how long do we follow them up? Once we diagnose KD, we follow them up virtually for life. So we initially follow them up every month, then we give them 6 monthly appointments, but we continue following them up for life. This was our first patient with KD, whom we had reported in 1996. This is what he looked like in August 2014. He had done his engineering by this time, and just last month, I asked him to send me his photograph. So he is now presently working in Vietnam. He's presently posted in Vietnam. So this is almost 30 years after he had KD. Kawasaki disease remains a riddle wrapped in a mystery inside an enigma. We don't know the cause, we don't know how to diagnose it, and we know very little about the treatment. But perhaps there is a key, and that key lies in genetics. A lot of work has been done on genetics of Kawasaki disease, and this started from a very important observation. We know that the highest incidence of KD is in Japan, more than 350 per 100,000 children below 5. What they found was there were some Japanese settlers in Hawaii. The incidence of KD in children of these Japanese immigrants in Hawaii is the same as in Japan. And this was much higher than the US citizens. So that was the first clue that it has a strong genetic component. So a lot of work has been done on the genetics of KD, and this has been led by Dr. Yoshihiro Onichi, who again had come to our institute in 2018. So he has been working on these patients. Several target genes have been worked upon through family-based studies, through population-based studies, and based on these, they have been able to identify some genes which may be responsible for the pathogenesis of KD. At Chandigarh, we also have been working on some of these genes that have been delineated by Dr. Onichi. This was one of our first few studies on CCL5. This is a recent study on the ITPKC, which was worked upon by Dr. Onichi. And while there is some association with some mutations, you can't have a cause and effect relationship that we can identify in our population. This is our work on the CD40 single nucleotide polymorphisms, thrombomodulin gene, worked by Dr. Ankita Singh, who was our DM student. And this is the ORAI1 gene, worked by Dr. Johnson, and caspase-3 again. So these polymorphisms seem to be higher in our children with KD, but there is definitely no cause and effect relationship on these. Dr. Himanshi, who was our DM student and who is now working at the Ruby Hall Clinic in Pune. She is settled in Pune. She worked on the microRNAs in KD. No significant differences was found out between KD and controls, but this was her DM thesis. So to summarize, KD is being increasingly recognized in India, and this is very encouraging. Most pediatricians in our country are now familiar with KD, and a lot of this credit should go to the Indian Academy of Pediatrics, because at every meeting of the IAP, every national meeting, there will be topics related to KD. And in most conferences, there will be more than 2 or 3 talks on KD. So I think IAP deserves all the credit. Diagnosis, even after more than 50 years, is still more art than science. Less science because we don't have a biomarker. KD can have many, many clinical presentations. So as pediatricians, we have to be familiar with the nuances involved in arriving at a diagnosis of KD. When should one suspect KD in children? And this should be known to not only pediatricians, but all doctors, all physicians should know that whenever you have fever more than 5 days in a child who is less than 5, think of KD. Don't miss KD. Irritability out of proportion to fever. Children with KD are very irritable. And if you have seen a few children with KD, you would recognize this irritability. Whenever you have fever with rash, don't jump to a conclusion of measles or some other viral rash. This could be KD. The rash in KD can be of any type, but not vesicular. It's not like the rash of chickenpox. A vesicular rash rules out KD, just as conjunctival discharge rules out KD. Fever with swelling over dorsum of hands and feet, especially if this finding has been picked up by the mother, this is KD. And sudden appearance of unilateral cervical adenopathy in a child, may not be just suppurative lymphadenitis. This could be the presentation of KD. It is the commonest vasculitis of childhood, and it is more common than all the other vasculitides combined. That is how common KD is. Before the pandemic, as I said earlier, we were picking up between 100 to 150 children with KD every year in a small city like Chandigarh. Over the years, the incidence of rheumatic fever has come down, and this is documented in this article in the Indian Journal of Medical Research by Dr. Kumar from Cochin and Dr. Raj Tandon from Delhi. So the incidence of rheumatic fever is coming down. It has virtually disappeared, while the incidence of KD is going up, and our projections are that by 2025, our incidence at Chandigarh would jump from 10.6 to somewhere around 20 per 100,000 children below 5. Kawasaki disease was described by none other than Dr. Tomisaku Kawasaki, and he used to organize what were known as International Kawasaki Disease Symposia, which were held every 3 years. This used to be a 3.5 days meeting, and Dr. Kawasaki would sit through the entire 3.5 days, even in his late 80s, early 90s. So the last symposium where we had the occasion to meet him was in 2018 at Yokohama. And here is Dr. Kawasaki with the Young Investigator Awards, and 3 amongst the award winners, Dr. Ankur Jindal, Rakesh Pelani, and Ankita Singh, happened to be from PGI. So this is Dr. Kawasaki sitting in the front. This is Dr. Kawasaki again at Yokohama with his 2 daughters. And one of these 2 daughters would be coming to PGI in October. We are having a meeting on Kawasaki disease from October 4 to October 8. And Subura Kawasaki, the one on the left, she would be joining us in October. So we don't have Dr. Kawasaki to meet now, but we have requested her to join, and she has very graciously agreed to come for our meeting. This is Dr. Kawasaki at Yokohama on a wheelchair, still active, alert, and even at that age, the smile was still there. He was 93 years old at this time. He still had that smile. So here he is with our DM fellows who had gone there to attend this meeting. As I said, he picked up his first patient in 1961, Shunichi Yamazo, and this is Shunichi Yamazo 60 years later, wishing Dr. Kawasaki a happy birthday. So his birthday fell on 7th February, and Dr. Yamazo he used to make it a point to wish Dr. Kawasaki every 7th February. Mr. Yamazo has since retired, and he now leads a retired life, but Dr. Kawasaki maintained his contact with him throughout his life. In 2010, I had the opportunity of visiting Dr. Kawasaki at the Kawasaki Disease Research Center, and I requested him to take me to the Red Cross Medical Center where he had worked. So we went by the Tokyo Metro, and he was in his 80s at that time. So he took me very graciously. He took me. The journey was almost 1 hour long, but he took me, and here he is standing in front of the hospital where he spent 40 years, where he diagnosed this condition and refused to leave this hospital. He retired as the director of this hospital and never took up a teaching position. So this is one of the few medical conditions which was diagnosed by a doctor, not by a professor. So he remains Dr. Tomisaku Kawasaki, not Professor Tomisaku Kawasaki. He was very proud of this hospital, which gave him the opportunity to pick up this condition. This is a very precious photograph taken a few weeks prior to Dr. Tomisaku Kawasaki's demise in 2020. He died during the pandemic, but not because of the pandemic. And here he is seen, Dr. Kato is shaking his hand. Dr. Kato remained his lifelong friend, and they are visiting Dr. Kawasaki when he was admitted for his terminal illness. So he is accompanied by his 2 daughters and his son. And on the right is a photograph, again, held by his daughter after he had passed away. This was the Kawasaki Disease Research Center, where he used to meet people and where he used to coordinate the research. And I personally had the occasion to visit him at this center twice. And he was very gracious, very, very gracious. And this is his memorial adjacent to the Japanese Red Cross Medical Center, where both Dr. Kawasaki and Mrs. Kawasaki were laid to rest. Mrs. Kawasaki was also a pediatrician. And his daughter visits this memorial every week. That is how devoted she was to her father. And on her left is Dr. Kawasaki's son. So Dr. Kawasaki breathed his last on June 5, 2020. He was 95 years and 3 months when he died of natural causes. And he used to say, be strict while studying medicine. He was very meticulous in his records, very, very meticulous. But be warm-hearted while caring for patients. And as I said earlier, anyone who has met him would realize that his face used to bloom in the presence of children. And this is a great man throughout his life who was opposed in the first 15 years of his career by the big academics of Tokyo University. The big professors of Tokyo University refused to accept that what he was describing was something new, refused to publish his papers in the standard pediatric journals in Japan. He persisted, fought, challenged them, and challenged them using clinical findings. At that time, there were no immunological investigations. Challenged them. They never liked it. So he met with stiff opposition from his peers in Japan for at least 15 years. Slowly, reluctantly, they accepted that what he was describing was indeed a new disease. Thank you very much.
Thank you, sir, for your insightful deliberation of prestigious Dr. M.B. Patil Oration 2023. Now I request our Honorable Vice Chancellor, Dr. R.S. Mudhol, sir, to please present a certificate of appreciation on behalf of BLD deemed to be university as a token of gratitude from us. Thank you, sir. Now I request Honorable Vice Chancellor Dr. R.S. Mudhol, sir, to please deliver his presidential remarks.
Good afternoon to everyone. Very honorable chief guest, Dr. Surjit Singh from PGI Chandigarh, Pro Vice Chancellor Dr. Inamdar, Dean Allied Health Science Dr. S.V. Patil, In charge Principal Dr. Sumangala Patil, and Research Director Dr. M.M. Patil, all the professors, teaching faculty, invitees, and dear students. It's a very touching, very apt to the occasion, as has been, the oration is in the name of Dr. M.B. Patil, who is a Karma Yogi and who is very well for the education, and always he wants research to be in the forefront in the education. He himself is an engineer by profession, he's a politician, he's a minister. More than that, he is a very societal man. And I thank Dr. Inamdar choosing such a apt person for such a oration. I think all previous 4 orations out of the 2 could not be done because of the pandemic. I think all our previous the orators were also the caliber. Last year we had Padma Shri, Madan Kodbole, who was again researcher. And today we have got, every year we are getting the better researcher. So we had a research week, stem cell research workshops, IPR, patent workshops, and end of this research week, we had the very good, we have very good guest, and who is a researcher. Research, coming to the research, I think we do some sort of research, publish, and leave it at that point. See the story, what has happened here, research. Simple fever to the vasculitis, skin condition, coronary condition, myocarditis, many people have contributed. So research should be of this nature, and I feel myself very happy to be with all you for this oration, the real Kawasaki disease, how it is being evolved. And at the end he said it is an art, again on the clinical platform, not on the laboratory platform. Many conditions may be like that. And rheumatic heart disease or rheumatic fever is declining, but the Kawasaki disease, and we may be having around us, but we are not able to diagnose it or pick it up. I think with Dr. Inamdar and the Dr. Surjit Singh's advice, I think in our center also in pediatric department, MM Patil and SV Patil and Dr. Inamdar start reporting. I think first case should be reported. That's what we may be having. We may be, they must have treated also like any other fever. I think I feel very happy that this is the research, this is how we have to take, not just the publish or perish, that is our very well-known dialogue, not publish, perish, in between there is a, again, search the research. Research, I think all of us have to today understand, research ourselves. And I think very young dynamic Dr. M.M. Patil and Dr. Chandrika who take the research, something that we have to search. And I think such stalwarts we calling to our university and getting the insight of the disease or research, a long way to go. And our young, the students have to pick up from here what you want to become. It is not again one more clue he has given with Kawasaki, not that professors at the university are all that authorities. Anybody can be authority if he is disciplined researcher. Definitely, he need not be a professor at university. He can be anywhere and still he can do the research. Thank you, sir. Hats off to your insight of the Kawasaki disease. I request all of you give a standing ovation for honor to him. Thank you very much, and we are honored with your presence and your lecture and a rare disease which is haunting all of us. Thank you, sir.
Thank you, sir. Distinguished Chief Guest, respected Honorable Vice Chancellor, Pro Vice Chancellor, other dignitaries on the dais, and everybody present here. It is with immense gratitude that we conclude this captivating oration lecture today. I, on behalf of BLDE deemed to be university, am deeply honored to have the privilege of hosting Dr. Surjit Singh, whose words I'm sure have ignited all our intellect and our passionate learning. Your insights have undoubtedly left an indelible mark on us. Thank you, sir. I thank our Honorable Pro-Chancellor, Dr. Y.M. Jairaj, sir, who couldn't be here because of his other commitments. I sincerely thank our Honorable Vice Chancellor, Dr. R.S. Mudol, sir, for being a constant source of encouragement in all our endeavors. Thank you, sir. I extend my sincere gratitude to Dr. Arun Inamdar, Honorable Pro Vice Chancellor, for being instrumental in getting our esteemed guest amidst us today. Thank you, sir, for always backing us in all our intentions. I also thank our Registrar, Dr. R.V. Kulkarni, sir, the backbone of all our events, and for supporting us. I am grateful to the Deans, the Dean Faculty of Allied Health Sciences, Dr. S.V. Patil, sir, Dr. Sumangla Patil, Vice Dean, Faculty of Medical Sciences. I extend our sincere gratitude to all the faculty members who are gathered here, heads of department, and all other dear students. My heartfelt thanks to our diligent faculties of university, non-teaching staff of library, R&D cell, and technical support system for seamlessly orchestrating every aspect of this event. Lastly, to the audience, your presence here today speaks volumes of your commitment. Thank you, one and all. As we depart with new perspectives and heightened inspiration, let us remember that journey of learning is an ongoing one. May the lessons that we have learned today guide us in pursuit of knowledge and excellence in future. Thank you, everybody. Have a great day ahead. Before we depart, I request everybody to please rise up for the national anthem. I request all the pediatricians to please stay back. And this is for the information to all the audience that today's lecture is available on BLDE's YouTube channel. I request all the pediatricians to please come up on the stage. Tea biscuits have been arranged at the back of the auditorium. So please, I request everybody to proceed.